Hello, everyone. Good afternoon. This is Professor Nlenga. I'm a clinical sonographer, currently heading the Department of Diagnostic Medical Ultrasound at Lusaka Apex Medical University. Today's topic, I'm going to discuss introduction to echocardiography. And I must emphasize that echo has got levels of training, which I'm going to take you through. But for you to understand most of the basic principles of echo, you need to be very, very thorough in some of the basic concepts. And some of the basic concepts that I need to explain to you includes the following. You have to do the basic principles of echo, which should encompass things like the Doppler modalities, which includes the 5 Doppler modalities like pulsed wave, continuous wave, powered Doppler, and also TDI or tissue Doppler imaging. Not forgetting color flow. These modalities are very important for one to understand so that you can do a comprehensive echo. I also have to talk about things like the principles of M-mode. And some of these principles of M-mode includes how M-mode can be used in the analysis of some of the structures of the cardiac. So most of the structures that are emphasized on this one, it's the mitral valve, and the pulmonic valve, and also the aortic valve. It's very important for you to understand how this M-mode analysis helps when it comes to the analysis of such structures, because it can also help you to pick some of the pathologies and some of the echo features that can be explained and give you some clues on what is happening within the heart. I also have to explain things like hemodynamics. Hemodynamics is one of the most important study that you must know. And this is nothing but the study of the flow of blood within the body system. The principles of hemodynamics are very important to understand because they help you to understand the intracardiac pressures that are taking place within the chambers. As long as one is not thorough in these hemodynamic changes, it becomes a challenge to understand some of the principles and findings of echo that comes in. Not forgetting the patterns that we get from different signals once we apply our Doppler modalities. Still, these hemodynamics becomes very key. And one of the key equations that we use in hemodynamics to calculate some of the echo findings is simplified Bernoulli's equation. To be specific, simplified Bernoulli's equation helps us to understand some things like how to come up with the quantification of pulmonary hypertension. This is where you use the right ventricle systolic pressure, which is equal to the 4V squared plus RAP, where the V in the equation is the velocity of the tricuspid regurgitation, and where also the RAP, which is the right atrial pressure. I'm going to explain later on how the equation of the simplified Bernoulli's equation comes into play and how it helps to quantify pulmonary hypertension. It's very important, this equation, to be acquainted with, because it also gives you a clue on how things must be done. In the ultrasound machine, you find that this equation, they are embedded there. And you don't need to cram the equation, but you need to understand the basic principles and what should be done at the end of the day. There is also a continuity equation. This continuity equation is very important. It also helps you to understand in cases of stenosis. For example, if you have got an aortic stenosis, this becomes very key also to understand what are the pressure gradient between the LVOT, which is the left ventricle outflow tract, and also the aortic part of the system. The flow equation also is very important. This principle, the flow equation, becomes very key. I'm going to illustrate it and you see how it comes and it plays a role. But the simple logic demands that the flow equation states that, or it's equal to the pressure gradient over the resistance, meaning for flow to occur, the pressure gradient must exceed the resistance that is there. And then we are also going to look at the standard echo windows that are done in echo. I'm going to illustrate them. There are basically 5 standard echo windows. And I'm also going to give you the views that are also entertained within the echo. I'll discuss the issue of the patient preparation and the examination that is involved. So having said that, I want to encourage you that this echo or the introduction of echo becomes very important. Some of you may be practicing echo already, but I don't want to take things for granted because this is very important. Once you get the concepts of the basic principles and the physics that is behind echo, it becomes very key for you to understand what is ahead of you. So I'll simply discuss the basic principles. And these basic principles of Doppler, there are actually 5. So number 1, we have pulsed Doppler or PW. Number 2, we've got CW. Number 3, we've got TDI or tissue Doppler imaging. Number 4, we've got color Doppler. And number 5, we've got PD or power Doppler. I should mention that we don't use power Doppler in echo. So I'll do this just to make sure that we pay attention. So we need to understand how pulse Doppler, continuous Doppler, and TDI, and also color Doppler, and why they are used in echo. Because when you understand why they are used in echo, it becomes very key to use them in a very systematic way. I've noticed in my practice that most of the people practices echo, they do things in a very spontaneous way. So we need to understand that we have to have a methodical study. We need to have the protocol. So the first protocol that you need to use when you're using these is that you need to know when to use the pulsed wave. And basically, you need to understand that this pulsed wave, this is a type of Doppler modality in which a single pulse is sent. So you have your transducer there, and then you have an object there. So you send one crystal, you send one pulse that goes there, and then once it strikes the object, the same pulse goes back to the transducer. So there is that pulse duration that is in between them. So once you send the pulse from your transducer, this transducer comes to object A, for example. This is structure A and this is structure B. And you find that the same pulse has to go back to the transducer, waiting for the other pulse which is being transmitted. So we have a pulse duration. And because of that, there is a lapse of time in between the pulse, the first pulse, and the second pulse that is sent back to the transducer. So this pulse wave has to be known. It has got some of its advantages and disadvantages. And some of the characteristics or qualities of pulsed wave is that it measures specific velocity. So specific velocity measurements, it's very, very key when it comes to pulsed wave. By the way, you must understand whenever you talk about Doppler, you are basically talking about measurements of blood velocities. So pulsed wave tends to measure blood velocities. It's very important because in echo, we are going to see how this specific velocity becomes very key. Number 2, you also have to remember that this pulsed wave measures laminar flow. Laminar flow. This is normal flow that is measured within pulsed wave. And if you find somebody is using pulsed wave to quantify abnormal flow, just know there's a problem somewhere. So you need to understand that laminar flow only measures low velocities which are normal, or rather parabolic flow. And these parabolic flow must be understood in this form. So you find that if you have, let me just illustrate this point. Let's assume this is our vessel. Let's assume this is our blood vessel. Let's assume this is our blood vessel. So what it is in this one, you find that at A, B, C. Okay, let's assume this is our blood flow. if this is our blood flow at A, B, and C, you find that the blood that is moving adjacent to the walls of this blood vessel, because of the walls, you are going to have this resistance. Resistance in the sense that blood is not just a liquid, but there are also solid components that are within the vessel. So you are going to have resistance against the wall. So the velocity at A and the velocity at B, they are not the same. Why? Because of the resistance. But you are going to have the maximum velocity at B. This is where you are going to have the maximum velocity at B. And this, we call it as a parabolic flow, parabolic laminar flow. So you can see as this flow is coming towards this side, it's forming a parabolic curve, and this is a parabolic flow. And this is why when we are measuring velocity using pulsed wave, we open our gate. So this gate, it's actually picking specific velocity at a specific point. So this point of specific velocity becomes very key to understand when you are using pulsed wave. And then you also find that you are going to pick whether it's a laminar flow, which are low velocities. So specific flow velocity becomes very key to understand it in this manner. And then you're also going to find one of the other properties of this pulsed wave, because it measures low velocities, it is also affected by aliasing artifact. And what is aliasing artifact? This is an artifact that is encountered by pulsed wave Doppler, in which the maximum velocity is reached by the pulsed wave, or where the Nyquist limit is actually reached. So once the Nyquist limit is reached by pulsed wave, you are going to have an aliasing artifact. And you are going to see again how you can identify that you are having an aliasing artifact. What are you supposed to do once you see aliasing when performing this Doppler examination? There are ways in which you can actually avoid and correct this aliasing. And one of them is that you have to adjust your baseline. I hope we are okay with the baseline. The baseline must be understood whenever you are dealing with spectral Doppler. So if this is your spectral Doppler, this horizontal line is your baseline. And this is your baseline. And you are going to have the vertical line, which is the shift or displacement. So this baseline helps you to know the positive shift and the negative shift. And this negative shift should also be understood. So once you have aliasing, which is, so for example, if you have your peak systolic velocity and the end diastolic velocity, so once you are having aliasing, so like I mentioned, aliasing, this is when you cannot pick the maximum velocity that is being recorded there. So the best thing that you must do is to adjust. You adjust the baseline. Your Doppler machine is going to have this spectral pattern. So you adjust the baseline, and this baseline has to go as much as it can go downward so that you can accommodate the maximum velocity that is there. But even when you adjust your baseline down to the baseline here to accommodate, you find that if there is a true aliasing, you are going to find that you still won't pick the maximum velocity. So what do you need to do? You switch this Doppler into continuous wave. So continuous wave becomes key. Why? Because it measures higher velocities. And you only find higher velocities where there are abnormal flows. So in cases of abnormal flows, you are going to find that you have mitral valve regurgitation, aortic regurgitation, pulmonic regurgitation, and any other regurgitation that may affect a valve. You can also have higher velocities between shunts, or maybe where you are having a VSD or an ASD. These may become very, very important. So whenever you are measuring higher velocities, make sure you use continuous wave. And the adjustment of this aliasing becomes very key. So switch on to continuous wave when correcting aliasing, or adjust the baseline. That way you are going to see how this pulsed wave is going to be controlled. So this is all about pulsed wave Doppler. When it comes to continuous wave, when it comes to CW or continuous wave, just like we saw on the pulsed wave, with this one, you are going to have your transducer there. This is your transducer. So you send a signal or a pulse to an object A, and this object A, you are going to have two pulses that are sent. They are sent to the same object. So one pulse, it will be sent at the same time. You're sending one pulse, the other one is taking it back. So there is continuous sending of pulses at the same time. So you are recording. Once you are picking the signal, you are also sending the signal. So there is no lapse. You are going to find that the PW, there is no pulse duration here. There is nothing like you are waiting for the other pulse. So all the pulses that are being sent, they are being continuously received. As a result, continuous wave tends to have other characteristics that you must know in Doppler. Number one, you are going to find that continuous wave measures higher velocities. So it measures higher velocities, contrary to pulsed wave. And these higher velocities, they are very important to note in cases of VSD or shunts, or also where you're having a regurgitation, because it will help you to quantify how much pressure gradient between the two valves that are there. And because of that, you also find that continuous wave also, it's non-specific. So it is affected by range ambiguity. Now, being non-specific, this is non-specific. Being non-specific, it simply means, I talked about having blood in a vessel. So you find that it doesn't measure specific velocity because it doesn't have a regulated or sample volume that is there. So this is another problem that you can find with continuous wave, because it is affected by range ambiguity. Range ambiguity. Range ambiguity, it's just another Doppler artifact that is affected, that affects continuous wave due to poor or failure to detect the exact depth of the velocity that you are picking. Hence, this is also another challenge that you are going to face when you are using continuous wave. It's also very important to note that this continuous wave tends to help you in the quantification of most of the abnormalities that are there. So the point that I should emphasize here is that don't use continuous wave to quantify normal velocities. Instead, use pulsed wave to quantify your normal velocities. When it comes to TDI, which is another Doppler modality, this is another special and important Doppler that you can find. By definition, TDI or tissue Doppler imaging. So by definition, this is a type of Doppler modality that only measures velocities, or rather tissue velocities. And particularly, this is used in cardiac examination assessment. So we measure the myocardial velocities. I'm going to illustrate how this TDI helps, and it also measures velocities that are less than 20. So TDI measures velocities. It measures velocities that are less than 20 centimeters per second. So this is what TDI does. Now, for you, and particularly this is used for diastolic assessment of the left ventricle. You are going to see how this TDI comes. And when you want to use this TDI, it's also very important to know when to use it and how to use it. So first thing first, you must make sure that you understand the apical four-chamber. This is apical four-chamber of the heart. This is your apical four-chamber. So you have your apical four-chamber here. You have your apical four-chamber here. Don't worry about what is apical or what is what. We are going to explain some of these terminologies. But for now, make sure you get your four-chamber view, which we call apical four-chamber. This is the standard abbreviation for apical four-chamber. You are going to have your left ventricle, your right ventricle, your right atrium, and your, this is our left atrium, and this is our right atrium. So once you pick this one, and I'm also very, very particular, when you look at the drawing, the tricuspid valves, they are slightly higher than the mitral valves. These are your mitral valves, and these are your mitral valves, and these are tricuspid valves. This is your septum, and this is your arterial septum. This is the free wall of the right ventricle, and this is the free wall of the left ventricle. So you pick your apical four-chamber and you press on the machine, you press or activate the button for TDI, which is tissue Doppler imaging. It's going to give you a scale just adjacent to that, and that will be less than, this will be positive 20, negative 20. So once you activate, you use pulsed wave. Pulsed wave, you are going to put your scan line at the mid-annulus. So you put your pulsed wave at the mid-annulus. I'm going to explain that. Now, why are you putting at the mid-annulus? This is where the annulus is. So you have to make sure that you check how this is being done. So you basically pick it like that. So once you put your pulse wave at the annulus, remember the annulus, it's a ring. It's a ring in which the mitral valves attaches, so you are able to know where the level of the annulus is. It's around here. So once you put your pulsed wave there, you are going to see the movement. Remember, we are measuring the movements of the left ventricle, both in systole and in diastole. And you are going to have a wave like this. You are going to have a wave like this. You are going to have a wave like that and a wave like that. This is very typical, and this will be our S prime, E prime, and the A prime. Now, what does it mean? It simply means at this point, when the left ventricle contracts, it moves upward, or it goes apically. It goes to the apical level. So at this point, you are going to have a positive shift during systole. So this positive shift, it's recorded as a signal that is going upward. And this is why this is called the S prime, or the systolic excursion. And then when the left ventricle relaxes, it also has to come down. Remember, this is the velocity we are picking. It has to come down, and this is the relaxation. And then you have your A, which is a further relaxation. So you've got two waves, the E and the A, which relaxation and further relaxation. So this is very, very important to take note. Now, if you understand what the EA ratio is on transmitral inflow, this is basically the mirror image of that. Normal TDI on the mid-annulus, the E must be taller. The E must be taller or longer than the A. So this is the normal relaxation of the left ventricle at the mid-annulus. And we can also measure the velocity, this velocity of the E from this point. From this point, we can measure the velocity. Normal should range between 8 to 10 centimeters per second. So this is the velocity that you must pick at the E prime. Basically, this is called the S prime, the E prime, and the A prime. You put this is the A prime. So once you pick this one at the mid-annulus, it becomes very easy for you to assess your diastolic function. I should also mention here that the S prime can also be used to actually assess the systolic function of the left ventricle. How? The criteria is that you look for the peak systolic velocity. So if the peak systolic velocity is more than 5 centimeters per second, it simply shows you that the left ventricle systolic function is very normal, or it's above 50%. So this is also another indirect assessment of the left ventricle systolic function. From there, you have to also measure the free wall. Remember, this is the mid, and then this is the free wall. So you pick your pulsed wave, you put it also on the left side, but more on the lateral free wall. Again, you are going to have another wave similar to the mid one, except this one is going to give you, again, something like this. It will have a systolic, but this one will be more longer than that one. Again, this will be your S prime, your E prime, and the A prime. Now, you find that the velocity of the lateral free wall is higher. Typically, recommended it should be more than 14, between 12 and 14, between 12 and 14 centimeters per second. The velocity, and this velocity is the up and down. This is the velocity that we are talking about. So one may ask, why is it that the mid velocity and the lateral velocity, they are different? The reason is very simple, because this mid annulus, it's more fixed. While this is a free wall, so the motion of the annulus is more free, hence the velocity tends to be higher. This again can also help you to understand the velocities that are between here and there. And you are going to see when we come to discuss the diastolic assessment and their parameters, in restrictive filling, all these velocities that I'm talking about, you are going to find that they are reduced. So it's very important for us to understand what these two velocities helps us to pick. So this was tissue Doppler imaging. We are going to now pick color Doppler, and this will be our last one when it comes to the principles of Doppler. Okay, so our TDI is done. We are going to see now color Doppler. These Doppler modalities are very important because they help you to be more methodical and systematic whenever you are doing things. If you want to know about color Doppler, think about one thing. It simply shows you the direction of the flow. I always joke with my students, this has got nothing to do with whether it's oxygenated blood or deoxygenated blood. So red, you are going to have a scale which will look like this. You are going to have a scale which will look like this. This is red and this is blue. The basic principle is that this is a positive shift, this is a negative shift. Red means towards the transducer and blue away from the transducer. Sometimes we use this acronym called BAT. This simply means blue away, red towards. Blue away, this is away, red towards. So towards the transducer, away from the transducer. This principle helps you to understand how the flow between the chambers and the valves tends to occur. And you are able to pick whether you are dealing with a regurgitation or normal flow. It's also very important to understand the normal physiological flow of blood between valves that comes into play. So this is very important for one to understand whenever you are dealing with color. I'm going to demonstrate later on as we give these lectures how this color flow tends to help you. Be aware of the color scale, which I'm also going to discuss later on. The color scale also can actually be very confusing if you don't know exactly how to use it. Be also aware of color aliasing. This is another artifact that you can also see during color Doppler imaging. So this is color Doppler and how it does. The basic principle and what you need to know about color Doppler is that it actually shows you the direction of flow and what is going on there. For example, if you have a scale like this, and then, so color flow doesn't give you a spectral Doppler pattern, but it shows you the direction, whether you are dealing with regurgitation or you are dealing with the normal flow. For example, this is your heart, again, your apical four chamber. So remember, this is an upside down, so you're going to have your left atrium and your left ventricle. Typically, the blood flow must move from the left atrium going to the left ventricle. So as blood moves towards the left ventricle, it's a positive shift. So it will give you this red towards the left ventricle because it's moving from here going that side. This is the direction. This can only happen when the valves are open. The moment the valves are going to close, or cohabitate, you are going to find that these valves will close like that. Now, during closure of the mitral valve, you don't need to see anything coming backward because they are closed. So the moment you are going to see blue color when the mitral valves have closed, it means this valve is leaking. And this is called mitral valve regurgitation. This is a pathology. I should mention here that the mitral valve regurgitation, it's a systolic lesion. You only see it during systole. Why in systole? Because the mitral valve must be tight. So once you see any leaking that is coming from the mitral valve, you need to quantify and know its hemodynamic complications on the heart. The same applies to the tricuspid valve. You are going to see that you only use color. The only thing that can help you is color. You are going to have color just below the mitral valve. And even then, you only see it in systole. So both tricuspid regurgitation, both mitral valve regurgitation and tricuspid regurgitation, they are systolic lesion in the sense that you only see them in systole. And this has to be quantified when it comes to that. So these are the Doppler modalities that we actually use in echo, and it should be used meticulously so that you understand whatever may be going on there. So after discussing these Doppler modalities, you have to be very, very, very careful when to use what and how to actually use them. Because if you don't know how to use them, this may become a challenge to perform an echo. I'm going to discuss the other important thing about the principles of M mode. This is a very straightforward one thing that you must know about the principles of M-mode is to actually help you to measure or do the dimension measurements. So this one, M-mode, it's a very, very simple M-mode. This is not a Doppler modality, but what it does, it only does or measures dimensions. Dimensions. It helps you to do the dimensions. That is number one. Two, it has got excellent axial resolution. Axial and lateral resolution. I hope we understand what axial resolution and lateral resolution, but for clarity's sake, I can tell you this is how you pick axial and lateral resolution. If this is your transducer, you are going to have the beam. So this beam tends to give you this kind of appearance. So you are going to have an object at A, an object at B. If this is the structure, A and B, so axial resolution, this is the ability of an ultrasound equipment to differentiate two distinct structures that are along the ultrasound beam as separate entity. That is called axial resolution. While lateral resolution, if you have an image there or a structure there and another one there, these two structures, they are located at different levels and they are at 90 degrees to each other. Therefore, lateral resolution, this is the ability of an ultrasound machine to differentiate two distinct structures that are perpendicular to the ultrasound beam. And this M-mode has got a very good axial and lateral resolution when it comes to that. So it's very important to pick and understand the importance of axial resolution when it comes to M-mode. This same M-mode can also help you to pick some of the good pathologies that may be presented when it comes to aortic valve, mitral valve, and others. So I'm going to show you the M-mode principles when it comes to aortic valve. So let's take, for example, we have, this is our plaques. Okay, we have our plaques. Don't worry about these terminologies. I just want to show you how M-mode analysis helps. So when you do your M-mode analysis at aortic valve, some of you may not be doing echo already, but I just want to show you some of the things that you can pick, and these principles, they will make sense even as we go on. So when you put your M-mode analysis there, so I've said the M-mode, the basic principles of M-mode, it measures the dimension, it has got very good axial resolution, and it also measures the cardiac cycle and time. So these three things are very important: axial resolution, dimensions of structures and measurements, and also it also measures the cardiac cycle even as you do that. So when you place your cardiac, your M-mode line just at the aortic valve, you are going to have something like this. You're going to have something like this. This, whatever you are cutting here, it will be translated. Whatever is happening here, this will be translated in here. So you are going to also have, so this is what is happening, and down there you are going to have another line there. So this is the aortic root or diameter, this one, and then you've got the LA. So whatever is being cut by this line, it will be deflected in this form. Now, why are you having this aortic dancing? This is called aortic dancing, okay? It's because there is motion of the aortic root. So at this point, the aortic valve can close and open, close and open. So this line, which we also call the closure line, this is a closure line. This line, the closure line from there to there, this is when the aortic valves are closed. This is closed aortic valve, and once they open, it gives you this box or rectangle sign. So this is when they are closed, and then open. And then you also have to remember that the anatomical structures of the aortic valve has got three cusps. The first cusp, it's a non-coronary, the right and the left. So on this particular view on echo, we see the right coronary cups and the non-coronary cups. We don't see the left coronary cups on this view. This, you must take note of it. Now, there are some few pathologies. I'm going to tell you one just to show you the importance of the principles of M-mode. One of the pathologies that you can pick on M-mode, there are quite many, but I'm going to give you maybe two. One of them is that this line, the closure line, when it closes, it should be in the middle. Once you find that there is asymmetrical location or position of this, either it's up or down, this is another classical indication of a possible bicuspid valve. This is a congenital anomaly that you may find, and this M-mode analysis can help you to know whether you are dealing with a bicuspid or a tricuspid kind of. So you're going to see that it's actually asymmetrical and not right in the center. The other thing that you can pick, you can also find that instead of having a very nice box, like the way this box is, you are going to find something like this. Okay. So you're going to find this sharp notching. This sharp notching, it's called the mid-systolic notching. This mid-systolic notching, it's a very strong indicator that you are dealing with hypertrophic obstructive cardiomyopathy. Not all hypertrophic cardiomyopathy are obstructive, but when you are dealing with an HOCM, which is hypertrophic obstructive cardiomyopathy, be watchful to see that. And this is very important. Again, you can see it in other views that may actually give you that information. So this is how M-mode principles can help you to pick some of these pathologies. We'll discuss more pathologies that we may pick on M-mode analysis even as we proceed. That was M-mode analysis at aortic valve. You can also now see M-mode analysis. This is M-mode analysis. So this was M-mode analysis at aortic valve. Now we want to see the M-mode analysis. This is M-mode analysis. Still, we are having plaques. This is M-mode analysis at mitral valve tips. So this is at the tips of the mitral valve using the plaques. You are going to find that whatever is happening here, where this line is being cut there and there, you're going to have something like this. Don't worry about these drawings. We are going to discuss them further. So you are going to have this cave. This cave that you are seeing, the caving that we are seeing, it's because the septum at every point, it's contracting it's contracting, relaxing, contracting, relaxing. So M mode analysis, remember I talked about it has the ability to measure the cardiac cycle, and this is the cardiac cycle. So relaxation, contraction, relaxation, contraction. That continues at this point, at that point, and at that point. So the three measurements we are going to see, this point, it's this point. If I wanted this, I could have drawn it here so it just depicts whatever is happening, this is what is happening. Whatever is happening here, I'll show you inside. And whatever is happening, it's going to show you there. So this is how the mid part you are going to see. You are going to have this. You're going to have that. So this, what you are seeing inside now, this is what is happening here. This is what is happening there. So, and you have to ask yourself, these are the mitral valves. This is the posterior mitral valve, anterior mitral valve, posterior mitral valve. So when the mitral valve closes, it gives you a straight line, and this is your straight line. This is called the CD line. CD line. This is when the mitral valves are closed. Now, once the mitral valve opens, it's going to give you one anterior mitral valve. It will go up. This becomes the A wave. The anterior mitral valve, A wave. And then you are going to have the CD, sorry, this is E, not A. The E, C, D, E, again, the A. I'm going to explain to you what the E and the A means, but this is the pattern that we label and standard in echo. The CD line, this is when the mitral valves are closed. You are going to have the E when they are open and the A. Sometimes you can have the B line here, which is a pathological condition. So once you see this, this is normal. The E is very taller and then the E is very short. And that cycle continues. M mode is going to pick this part, that part, this part, that part. You don't need to master all of them because this is a cycle that continues to give you that. Therefore, you can understand at every point and what is happening so that you pick things. I'll give you two pathologies that can be picked at this point. So at this point, you can pick two conditions. One of them that you can pick is mitral valve stenosis. And you can also pick mitral valve prolapse. For mitral valve stenosis, I will simply tell you straight how it appears on echo. You are going to see, once you put your M mode here, I'm going to show you these images. I think I have some of the cases that I've in my archives. So once you pick this one, you are going to have, once you put your M mode here, so this DEA, it's going to be distorted. You are going to have what we call a plateau. So instead of having the DEA, you are going to have a plateau. This is a classical sign of mitral valve stenosis, MVS, mitral valve stenosis. So again, M mode is going to give you these principles that you are going to find, and you are going to pick it very, very, very well. Number two, you can also have mitral valve prolapse. When you put your M mode here, you are going to see the dangling or the bulging. So this is going to appear like that. This is a sign of mitral valve prolapse. So two pathologies again can be picked. There are quite a number of pathologies that can be picked. But the point I'm trying to emphasize is that M mode is going to give you some of these classical indications. And I want to emphasize one point: don't conclude echo findings on one parameter. Make sure you use at least multiple parameters so that they are able to pick you and give you information in a very conclusive way. Okay, let me just conclude by mentioning about the simplified Bernoulli's equation and then the standard views. Okay, so when you talk about hemodynamics, I'll just give you a very simple equation. And just to show you how it works. So it's very important, again, like I mentioned earlier on, to make sure that you understand this hemodynamics, because you cannot do away with the principles of hemodynamics when you want to understand how the heart operates and the physiological function that goes on there. Number one, and the most important equation, is the simplified Bernoulli's equation. This simplified Bernoulli's equation states that RVSP is equal to 4V squared plus RAP. Now, this shouldn't scare anyone. Just try to analyze all the equations and the variables that are there. So, RVSP, this is, just consider the heart. If this is your heart, let's pay attention on the right side of the heart. Okay, this is our left side. So if this is our right ventricle, this is our right atrium. One thing that we must know, that blood comes from all parts of the body. It comes to the right side of the heart, and this is the right side of the heart through the inferior vena cava, the IVC, that is draining the inferior part or the lower part of the body. And also we've got the superior part by superior vena cava, and also the coronary vein. So they all drain into the right atrium. Now, this right atrium has got valves that are between the right ventricle and also the right atrium. So for this blood to come into the left ventricle, it must be understood by the pressure gradient difference. As long as there is no pressure difference, blood from the left atrium is not going to come to the left ventricle. But once blood comes into the right ventricle, the pressure that is going to be generated in the right ventricle here, once it is pumped into the pulmonary circulation through the pulmonic valve, it is the same pressure that is going to be transmitted into the pulmonary circulation. Therefore, we can assume that the right ventricle systolic pressure is equal to the pulmonary arterial systolic pressure. This is very important. So why are we saying the right ventricle systolic pressure is equal to the pulmonary arterial systolic pressure? Pulmonary arterial systolic pressure is the pressure that is within the pulmonary circulation. Therefore, if we have this equation to calculate that, then we can assume that our RVSP is equal to the pulmonary arterial systolic pressure, provided there are conditions here, provided there is no pulmonic stenosis. That is number one. What is pulmonic stenosis? This is when there is occlusion, or rather, there is stenotic pulmonic valve. It simply means the pressure that will come here, it won't be the same pressure because there is blockage there. That is number one. Number two, provided the RVOT, the right ventricle outflow tract, this one, is not obstructed. There are conditions where you can have the RVOT, or the right ventricle outflow tract, is obstructed. So this has to be understood. So don't use this equation when there are these two conditions where there is obstruction of the RVOT or stenotic pulmonic valve. So this may not apply. But the principal guidelines in hemodynamics states that the pressure at point A, which is this one, and the pressure at point B, provided there is pressure difference, it will be the same pressure that goes on. So therefore, it's very important to understand where we use this equation. We use this equation to quantify pulmonary hypertension. The question comes in, what is pulmonary hypertension? Pulmonary hypertension, this is when there is raised pressure within the pulmonary circulation. Raised pressure within the pulmonary circulation. The question again comes in, what is the normal pulmonary pressure? Normal pulmonary pressure should be less than or equal to 25 millimeter mercury at rest. This is at rest. During exercise, it can go to 35 millimeter mercury during exercise. And anything above 35, 36 going up, so you can have between 35, latest guidelines will give you even figures like 40 plus, but 35 to around 44 millimeter mercury, this is mild pulmonary hypertension. Between 44 to around 64 millimeter mercury, this is moderate, and severe, anything above 64 millimeter mercury. So this is the grading of pulmonary hypertension. This is mild, moderate, and severe. So let's see how we are going to fuse these two equations into that. I should also mention that the gold standard to measure or assess or quantify pulmonary hypertension is by using right heart catheterization. And we all know that the right heart catheterization, it's an invasive procedure. So we cannot catheterize all the patients, so we can actually use echo to approximate the pressures within the pulmonary circulation using this simplified equation, which is embedded within the machine. So this is how it goes. You pick your apical four chamber. This is your apical four chamber. Apical four chamber. Remember, in our equation, which is RVSP is equal to 4V squared plus RAP, where V is the tricuspid regurgitation. So I want to emphasize, don't use this equation when you don't have a tricuspid regurgitation. We are going to look at these regurgitations and how it comes in. So once you pick tricuspid regurgitation, you are going to have something like this. Once you pick your tricuspid regurgitation, you are going to have something like this. You have this because it's a regurgitation, TR. Don't worry, we are going to explain where these tricuspid regurgitations are coming from. But just for illustration purposes, please bear with me. I need to show you. So this tricuspid regurgitation, it's a negative shift. If you remember, I explained about how the tricuspid regurgitation appears. So it's going to be a negative shift because it's a systolic lesion. So when you measure the velocity, for argument's sake, you find that this velocity, maximum velocity, it's around 3 millimeter per second. So you are going to put your 3 here. By the way, you don't need to calculate this one. The machine is going to do everything for you. So once you pick your 4V, your tricuspid velocity, you square it plus RAP. Therefore, when you square a 3, you are going to have 9. 9 multiplied by 4, this is 36. So you are going to have 36 millimeter mercury as your pressure gradient. But remember, you need to add your RAP, which is your you need to add your right atrial pressure. How you add and the methods you use has got a lot to do with a lot of factors. Factor number one, you must understand what are the normal intracardial pressures. So the normal intracardial pressures, they range between 0 to around 15. This is within the right atrium. So you can have 0, you can have 3, you can have 5, you can have 8, 10, up to around 15. These are considered to be normal ranges of pressure within the right atrium. How you pick, it matters, and how you also add, it also matters. Number one, you can consider the collapsibility of the inferior vena cava. During Valsalva application on the patient, you tell the patient to sniff. You are going to find that when they sniff, they breathe in. The right side of the heart behaves in a certain way. So you are going to have the collapsibility or collapsing of the right side of the heart, or the IVC is going to collapse. That is called collapsibility index. There are two physiological effects there. The intrathoracic pressure and the intra-abdominal pressure, they actually affect the collapsibility of the IVC. In a normal physiological function, the IVC must collapse. That collapsibility indicates that the pressures in the right atrium, they are normal. If the IVC is unable to collapse, this is an indication that there is a poor venous return. So you need to also measure the diameter of the IVC. And normal diameter of the IVC can range between 15 to around 2.5 to 15 millimeters to around 25 millimeters. So that range, that also can give you approximate, or you can actually estimate the pressures in the right atrium depending on the diameter. It's also very important to note that certain clinical findings that the patient may present with, they can actually give you a clue on what could be happening within the right atrium. So, for example, if I find that the diameter of the IVC is around 34 or 30 or 3.4, 30 millimeters, if I find it's very 30, I wouldn't be wrong to add to my 36 maybe pressures of around 10. I can add 10 or even 15. So when you add to your 36, that 36, remember we are here, 36 plus your RAP, I add, let me just pick, maybe I add 10, equals, I'm going to have a 46 millimeter mercury. Therefore, I can say RVSP is equal to 46 millimeter mercury. Now, you and me, we are able to tell that, and we know, we've concluded that RVSP is equal to pulmonary arterial systolic pressure. So we can actually now replace that this is equal to that. So if you are having a pulmonary arterial systolic pressure, which is equal to 46, it simply means you are dealing with a possible mild to moderate pulmonary hypertension. And the good news is that you don't need to calculate all these things because the machine calculates for you. However, you need to know when to apply your right atrial pressure. I think it was very important for me to emphasize on that point. The other thing that you need to know is the standard echo windows that are very important. And this will be my last part so that we can see what goes on in echo, having mentioned about some of the principles that goes on there. Some of these principles that we are discussing here, they may sound deep today, but we are going to iron them out and also see how they can actually help us to comprehensively understand these echo principles that comes in. So having discussed the modalities, the Doppler modalities, the principles of M mode, the hemodynamics, I've already done the flow equation, which talks about the resistance and also the pressure gradient. One thing that you must know about this one is that this flow equation states that for flow to occur, there must be pressure and resistance, and the resistance must be lower than the pressure gradient, or the pressure gradient must exceed the resistance for flow to occur. That principle is very, very important because it affects the hemodynamics of the heart chambers. So I'm going to discuss the 5 echo windows that we have so that we can conclude on this note. So this is echo windows. We are going to see the echo windows. Okay, the standard echo windows. Standard. So we are going to have something like this. So we are going to have this, this, we are going to have this, this, and that. So we've got one. Let me use the red pen just to illustrate. We are going to have 1, 2, 3, 4. Then this is our sternum. I should mention here that what we are discussing here is transthoracic echo. There are 2 types of echo, which I mentioned earlier on. There is transesophageal echo, in which you have to use a transducer going through your mouth and then coming to the chest cavity so that you can have that proximity between the heart and the transducer. There are indications for such examination. And we also have a transthoracic echo. This is where you have to use your transducer. You go through the chest cavity, the anterior chest cavity, and visualize what is behind it within the heart itself. It's very important to note that some of these investigations that you're doing, they may not be picked on echo, but they may only be picked on the transesophageal echo. So having drawn this, you have to understand some basic surface anatomy that you're supposed to pick. Number 1, you have to consider the sternum. The sternum is part of the thoracic cage where you pick the sternum itself, which is the bone, and it's one of the landmarks that you can use when actually visualizing some of these structures of the heart. And these are windows that we can use when you are actually picking some of these things that comes into play. So for you to access or to actually pick the heart, you need to have windows and also understand the positioning of the heart. The heart is positioned in the chest cavity, but more towards the left side of the heart at an angle of about 45 degrees towards the left. It's centrally located, but towards more on the left. So this anatomical variation, this anatomical position is very important even as you look at that. So it will look something like this. When we can have our imaginary lines, it will look something like this. It will look something like this. This is how it will look seated within our chest cavity. So after you pick this one, there are windows. The first window that we have, it's called parasternal. It's abbreviated as, so the first window is plaques. Plaques, this is parasternal long axis. Parasternal long axis. Why are we using parasternal? Because it's just adjacent to the sternum. This is our sternum. I talked about the sternum. Parasternal long axis. So I was drawing some of the views which were in long section. So you are going to pick the parasternal window. These are windows. Don't confuse windows and views. This is a window called parasternal long axis window. This is where you see your heart in long section. In long section, and there are specific structures that you can pick in long section. That is number one. Number two, you can also have the apical four chambers that you pick just below the apex. I'll explain them later. So, and by the way, this parasternal long axis, anatomically, the patient must be positioned in a specific position. The patient must be positioned in a specific position for you to pick the correct parasternal long axis. So the patient must be in the left lateral decubitus. Left lateral decubitus. And there are reasons for that. So once you put the patient in the left lateral decubitus, you are going to make sure that you facilitate the position of the heart towards the heart anterior chest wall, the thoracic chest wall. That is number one. Number two, make sure that the left arm of the patient is just behind or below the head, so that the patient is positioned like this but facing towards the left. That is very important because it also helps you to push the heart structures towards the anterior chest wall, and it's more closer to the anterior chest wall. And the transducer position, which I'm going to actually demonstrate, the position of the transducer is that the probe must actually be between 3 to 4 intercostal spaces. So this is where you put your transducer. You don't just put it anywhere else. It must be positioned at a specific position. Patient in the left lateral decubitus. I'm going to explain that when it comes to demonstration of that. That is number one. Number two position, you have to make sure that you put your transducer just below the nipple. Just below the nipple. And in this one, you pick the apical four chamber. Apical four chamber. This apical four chamber helps you to see the heart with all the four chambers. That is the two ventricles and the two atriums. You are going to see them, but this is the position where you put your transducer just below the nipple. But again, you are going to see that these nipples, they vary. Particularly in females, you can find that the mammary gland may be slightly more than the males. And you might find that for you to just do an echo, it may be a very big challenging thing. But you have to make sure that you entertain the nipple position. It may vary for you to get this one. I'm going to explain to you how this is done. The third point that you are going to see is that you are going to have the subcostal window. This subcostal window, it's also another important window that you have to make sure that you come and pick it within the subcostal region. What are the landmarks? The landmarks, they are the lower costal margin and the epigastric. This is where you put your transducer in coronal plane. There are two views there that you can pick. One, you put your probe in coronal plane and you appreciate the apical four chamber. And the other one where you pick the IVC. The IVC assessment in echo is very important, where you put your probe like this and then you pick your IVC. Then the coronal plane where you pick your heart and you pick your four chambers. And these four chambers, it can actually help you to do some of the assessment. Assessment number one that you can pick is to assess if there's any pericardial effusion. The other one, you can also pick the other free wall measurements of the right ventricle free wall. That can also be picked. These are very important to consider. And we've got the fourth one. This is the fourth one. And this is called the suprasternal window. So the suprasternal window, just by the word, the definition of the word itself, you find that this is the supra, just above the sternum. Suprasternal notch. This is the notch. So this is where you put the probe. You put your probe here, transducer pointing to the left. Some of these investigations and probe positioning, I'm going to show you the recordings on the actual demonstration so that you understand these positions. So suprasternal, you are going to see the notch or the aortic arc. You are going to see this. You are going to see the arc, the aortic arc. So the aortic arc, this is the arc that comes out of the left side of the heart through the aorta, and then it forms an arc. There are three branches that you can pick using this view, but the indications, the classical indications to pick, to use this window is to pick any suspicion of aortic coarctation. So aortic coarctation can also be viewed using this arc because you are able to pick the proximal and the distal part of the aortic arc. So this is very important to pick it from that angle. Number one, you can also see the branches. The first branch that you are going to see, remember the aortic arc has got the brachiocephalic artery or the innominate artery. You've got the left common carotid artery, which is also another direct branch from the aorta. And then you also have the subclavian artery, left subclavian artery to be more precise. So these three branches, you can pick them on the suprasternal window and you are able to pick exactly what may be happening there, and the measurements can be done to quantify if there is any dilatation, an aneurysm, or any possible coarctation that is being suspected. So these are the basic four windows that you need. The parasternal long axis, which must be picked between the third to fourth intercostal spaces with the patient in the left lateral decubitus, and then you pick this one in long section, longitudinal view. And then you are also going to pick the apical four chamber, where you pick the apical four chamber, the all four chambers are picked in that, and you are able to assess some of these investigations that we are talking about. We also have the subcostal, where you have two views, the coronal and the sagittal, and the suprasternal. In most cases, the fifth one, it's very rarely used unless there are specific conditions. The right parasternal long axis. Remember, we are using the sternum as our landmark. So this can also become very, very important when it comes to assessment. So these basic windows are very, very important to know, and they make more sense once we do the practical hands-on. I'm going to show you the other views that comes within each window so that we can know what you can pick and what you can assess. And this was, since this was just an introductory to echo, I'm going to summarize it in this way. Number one, we must understand that for you to do an echo, you must understand certain things that are very helpful for you to have a proper conclusion. Number one, you must understand that the hemodynamics and the Doppler modalities are very important. And these Doppler modalities, the basic 4 Doppler modalities, we use them in assessment of the cardiac structures. Number one, we've got continuous wave, where we explain that this continuous wave, this is a type of modality or Doppler modalities that measures higher velocities. Very important to measure abnormal flow velocities between the valves and also between the shunts. You can have regurgitations of the mitral valve, tricuspid valve, and the pulmonic valve. This is the most important Doppler modalities to use when assessing the flow velocities that are very normal. I explained the advantages and some of the qualities that this can pick. I also talked about pulsed wave Doppler modality, and this is the type of modality in which you are able to measure the normal flow velocities that are within the body structures or within the heart. And this is also affected by aliasing, which is an artifact which I demonstrated, and it can also help you to know that you are dealing with higher velocities. I mentioned also that it measures specific velocities that are within the body structures, and it is affected by aliasing as an artifact. I talked about tissue Doppler imaging. This is a type of modality, again, that measures only the tissue velocities, and these tissue velocities are very important to take note because it only measures velocities that are less than 20. These velocities that are less than 20, you are able to pick velocities within the annulus, both the mid-annulus and the lateral annulus. I mentioned that the mid-annulus, it gives you a specific waveform that can help you to know the diastolic assessment, in which the mid-annulus, you need to expect the velocities that are between 8 and 10 for the mid velocity. And for the lateral velocity, the lateral annulus, I talked about anything between 12 and 14, the velocity is regarded as normal. I talked about the S wave, which is the S wave or the systolic excursion. That is another wave that can also help you to assess the left ventricle systolic fraction when it is more than 5 centimeters per second on TD high. I also went further to discuss the color flow Doppler mapping, in which you can able to see that the flow direction is on this side and the flow of direction is on the other side. What is the importance in echo? I emphasize this helps you to know if there is any abnormal flow when it comes to regurgitations. I emphasize that color flow Doppler mapping is very important so that you understand also the normal flow direction of each structure of the heart that is there. I came further to discuss the M mode analysis both at aortic valve, mitral valve, where I talked about the mitral valve giving you pathologies that are happening within the M mode analysis. I demonstrated how you can see the mitral valve stenosis and how you can see the mitral valve prolapse using the M mode analysis. I also went further to discuss the aortic valve M mode analysis on how you can pick if there is a bicuspid valve just by analyzing the M mode analysis. I also went further to discuss the hemodynamics and how you can use the simplified Bernoulli's equation, where you can use the simplified Bernoulli's equation to quantify pulmonary hypertension. I gave an example of the pulmonary hypertension because this is one of the pathologies that can be used to quantify its pathophysiology using the echo. And I also mentioned that the gold standard to quantify pulmonary hypertension is by using right heart catheterization, which is an invasive procedure. And this procedure, we cannot catheterize all the patients. So ultrasound or echo becomes a non-invasive procedure in which we can use these physics and simplified Bernoulli's equation methods to actually quantify, where we said you can use right ventricle systolic pressure, which is equal to the 4V squared where V is a tricuspid regurgitation, and also where the RAP, which is the right atrial pressure, is the pressure within the right atrium. Very important to take note of the intracardial pressures, not only the intracardial pressures of the right atrium, but both on the right and the left side of the heart. We must understand those parameters that are there. And finally, I have also talked about the echo windows, which are 4 in number. I emphasize to say we are using the transthoracic echo method and not the transesophageal. These are 2 different methods of assessing the heart. The transthoracic echo you have to use just on the external wall of the anterior thoracic cage, and also the transesophageal. This is where we use the esophagus approach, where you have to pick the proximity of the heart. I talked about the 4 of them. We've got the parasternal long axis, where we use the plaques between 3rd to 4th intercostal spaces. And we also talked about the apical 4 chamber, where you can pick specific structures within the heart. And we also picked the subcostal view, where I talked about how you can analyze the actual 4 chambers using this heart, and also where you can pick the IVC. I emphasize that when you find that the IVC is being assessed or measured in echo, they are simply talking about the collapsibility index, which is also very important in echo to assess whenever you are doing this echo. I've also talked about the suprasternal view, where suprasternal window, this is where you can pick the actual arc. I was demonstrating here that you are able to pick the actual arc, and typically this is requested when you want to assess or suspecting any aortic coarctation, which is nothing but the narrowing of the aortic arc that is there. Not only that, you can also assess if there is any aortic aneurysm or if there is any dissection that is expected from this point. And then I also emphasized on the right parasternal long axis. This is very rarely used, but in cases where you have a dextrocardia, situs inversus, this is where you can see that the left side of the heart, or the heart is more on the left side than the heart is more on the right side than on the left side. This is very useful again. So thank you so much for your attention. So this is our first part of introduction to echo. I know this may be a little bit confusing, but we can still emphasize on some of these things. I should mention that some of these principles, they look so useless, but please, let's pay attention and grasp the principles that are going to help us to pick some of these investigations in one point. So thank you so much, and see you again. Thank you.